Hello everybody and welcome to Autism Awareness Training. My name is Dr. Ailish Mooney. I'm the Senior Clinical Psychologist in Cheeverstown House, and I will be talking you through some of the basics of autism and giving you a little bit of information about what you can do to support a person with autism. This training is primarily aimed at supporting adults with autism. Some of the information might be relevant for kids, but overall it will be aimed at supporting adults with autism. So the outline for today covers what is an autism spectrum disorder and how we can support people with autism spectrum disorder. So firstly, what is autism? So autism is a lifelong neurodevelopmental disorder, i.e. that means atypical brain development. One of the more common phrases that's been used to describe autism now is a phrase called neuroatypical. Becoming a more common phrase to describe people who don't have typical neurological brain development. The current research suggests that there is a genetic basis for autism with what we call spontaneous mutations. So there is a strong family link essentially between family members, and usually when we're doing assessments we do find that there is siblings or parents or grandparents or uncles that certainly meet the criteria for a diagnosis of autism, or at least had some of the symptoms that might be associated with autism. Not all diagnoses of autism have that genetic basis. There are what we call spontaneous mutations, which essentially means that in order for somebody to develop autism or to develop the symptoms of autism, the current research, genetic research, shows us that there has to be over 1,000 genes that spontaneously mutate. There is no specific combination that we're aware of yet that this is autism in a nutshell. We still don't fully understand it, and we are getting a greater understanding of what autism is, but we're very much so in the early stages of our scientific understanding of what causes autism. Autism always presents within the first 3 years of life, but it is important to note that it may only be diagnosed in later childhood or even in adulthood. So often it goes underdiagnosed, in particular with autism in girls. We're seeing a big influx in the Irish health system of girls in their teenage years with high levels of anxiety and social issues or issues around school refusal who are coming into mental health services. And we're discovering through the process of assessment and differential diagnosis that actually they have a diagnosis of autism, but they had gone under the radar for so long that they hadn't been diagnosed. And I suppose, why does that happen? Some people are really good at what we call social masking. So they're really good at masking any social difficulties they have, and they kind of turn themselves on when they're in social scenarios, and then when they go home they're really exhausted and really depleted by the effort it took to try and maintain appropriate eye contact and follow the social rules and try and tune in to what other people mean when they're not saying it. So I suppose we do diagnose people later than early childhood, in particular in intellectual disability services, which is where I work. There's a huge amount of adults who've only been recently diagnosed with autism, and I suppose why that is lots of psychologists and doctors in the past would have found that kind of labelling people with too many labels was unnecessary. And there was a bit of an attitude of, well, if the person already has a diagnosed intellectual disability, what difference does it make if they get the autism diagnosis? They might have had a diagnosis of Down syndrome or other issues on top of that. Whereas now we do try and diagnose people, because I think the more understanding other people have of how to interact with the person with autism in a way that is helpful for them, the better. 60 to 70% of people with autism also have a diagnosed intellectual disability, and it is important to note that not all people who have a diagnosis of autism will also have an intellectual disability. The ratio is currently 4:1 male to female, and there is a higher rate of men diagnosed with autism than women. It's hard to know whether there is a higher rate of men with autism than women, or if it's just that they're diagnosed easier. As I said slightly earlier, I think girls seem to be quite good at social masking, in particular in the early years. It seems to be a little bit harder to pick it up. So it's hard to know whether it's a diagnostic issue or whether that it's a presentation.
We are all different, and that's wonderful. Some differences are easy to see. Height, hairstyle, gender, eye color, and so on. Other differences can't be seen. Our favorite foods, fears, or special skills. Interestingly, the way we see the world is also different. For instance, what do you see in this drawing? Most people see a duck, but some of you might have seen a rabbit. Whichever you saw, you are correct. This is just a trick drawing to show you that all brains work differently. The brain is your body's computer. It works differently for all of us and controls how you learn. That's why we are all good at different things. How you feel, which is why we all feel different emotions. And how you communicate. Sometimes the brain is connected in such a way it affects the senses and how we perceive and read situations and interactions. This is known as autism. Many people have autism, so it's likely you already know someone who is autistic. And for this reason, it's useful to know a little bit about autism. The special wiring inside an autistic brain can sometimes make the person good at tasks we may find difficult, such as mathematics, drawing, or music. It can also do the opposite, and activities we find too easy are incredibly difficult to them, such as making friends. The senses constantly send information to your brain about your surroundings and other people. However, when a person's brain and its senses don't communicate well, the brain can become overwhelmed and confused, affecting how they see the world. Picture yourself walking down the street. This is how an autistic brain may experience the same walk. Scary, isn't it? Sadly, in many cases, the person can't say out loud how they feel. So even though there's chaos going on in their heads, they seem okay on the outside, unable to ask for help. We all develop behaviors to help us feel calm in uncomfortable situations. We may look away, hug ourselves, chew our fingernails, fidget, bite our lips, and so on. Equally, autistic people develop behaviors that help them cope with these intense moments. These actions may seem unusual, but they're just their way to feel calm. When they happen, it means they are having a hard time. The kind thing to do is not to give them an even harder time by getting cross, ignoring them, or mocking them. Remember, just because a PlayStation can't read an Xbox game, it doesn't mean it's broken. People with autism need friends who are willing to take the time to know them. With good communication and plenty of patience, everyone would be better off. People with autism are not ill or broken. They simply have a unique view of the world. And with a little support from their friends, they might just be able to share that view with us. Autism can make amazing things happen.
So that last video, I think, does a particularly remarkable job at describing what autism is. And the bit I particularly like is how it describes the issue of sensory overload. It's the idea of having crossed wires in your brain that when they all fire at the same time just becomes so overloading that you can't quite take in any of it. Another person that does a really, really good job at describing what that sensation is, it feels like, is a lady called Carly Fleischman. And if you haven't seen her before, I highly recommend you look up her YouTube videos. Carly is a young woman who has autism, and she communicates through the use of an iPad. So she types out what she wants to say. I think Carly presents as many of the people we support, the adults we support, in that she doesn't use language to communicate verbally. And often we can underestimate people who don't use language verbally to communicate with us. And often we assume that they don't really understand what's going on. I think what's really interesting about Carly's videos is she shows you just how tuned into everything she is, and Carly doesn't have an intellectual disability with her autism, and her way of describing her sensations, and the sensation of having to look people in the eye as being like having to take a series of photographs and put them all together, or the sensation of feeling touched, being touched by somebody else, is feeling like there's spiders crawling all over her skin. I won't try and do her justice by explaining it to you, but I would recommend that if you are further interested in exploring autism, watching her videos can really give you another insight into what it's like to have autism from somebody who experiences it. So, as I said, the focus of today's presentation is primarily on autism and people who have intellectual disabilities, and that is the service that I work for. So we're going to talk about, firstly, autism and a mild to moderate intellectual disability, and then the combination of autism and a more severe to profound intellectual disability. So firstly, mild to moderate. So the first thing to be aware of with people who have autism and a mild to moderate intellectual disability is there tends to be delayed language development. That doesn't mean that language or verbal language is non-existent, just that people in this category might have difficulty communicating. They might use repetitive use of learned phrases or echolalic phrases, which is that learned set of phrases that they repeat. Sometimes those learned phrases are meaningful and they are communicative, and sometimes they're used as a tool to self-regulate. Often people in this category will understand more than they're able to express in terms of their communication. But it is still important to remember that their language development is probably delayed. They may have difficulty understanding large chunks of information, so it's important to take time when you're communicating with someone with autism to communicate clearly, effectively, chunk information together that goes together, do it in sequential order. So, if you're giving a set of directions, give them in the order that they're to be completed, but ideally trying to give one instruction at a time. Give people time to process the information. They may have visual perception problems, so depth perception issues, walking down a stairs can be difficult, or stepping over thresholds. Perception of a person's face can be difficult for someone in this category, so focusing on details of the face rather than the whole face. And that obviously has significant implications for interpreting facial expressions. So if you're focused on a small detail like the way the right eyebrow is shaped, it might be difficult for you to interpret somebody's facial expressions if they're trying to communicate something non-verbally to you. Many people in this category can have difficulty understanding other people's intentions, or difficulty with what we call theory of mind. So that's a difficulty understanding somebody else's point of view and understanding somebody else's intentions, because people with autism find it difficult to be able to place themselves in somebody else's shoes. So to think about something from another person's perspective without having experienced their world or their perspective can be quite challenging for somebody with autism. People in this category may have obsessions or repetitive behaviours or restricted interests, or sustained interests in objects or part of objects. They often have a need for other people to create structure and routines, and this can be associated with anxiety levels as well. So autism and anxiety often go hand in hand, and having repetitive interests or restrictive interests, that's kind of like your safe area. It's the area that you're happy either being immersed in or talking about with somebody else. So common restrictive interests with people with autism would be trains, machinery, parts of cars, watching particular videos repetitively. So that kind of repetitive behaviour over and over and over again. So in children you often see things like lining up of toy cars, or obsessively being interested in Thomas the Tank Engine and absolutely nothing else, just that one thing. In adults it tends to be a little bit more wider variation of things that people are interested in, but I do think there is a strong preference for kind of the predictability of things. So we often see adults who like to watch the same movies or TV shows over and over and over again, and I suppose the predictability of knowing that it's going to be the same every time can relieve anxiety for people with autism. People with autism spectrum disorders are more likely to have more significant sensory needs. So when we're talking about theirs, we're talking about the need to seek or avoid sensory stimulation. Many people in this category have sensory sensitivities or have a low registration, so they might notice certain types of sensory stimuli much less than other people or much more than other people. And it can vary subtly and be different at different times across various senses. Some days it might be stronger than others, and I suppose it's important to mention that if somebody has an increased sensitivity or a decreased sensitivity to something, that doesn't mean they're like that all the time. It can vary from time to time. Somebody might have a strong sensitivity to particular types of noises, like a baby crying, or unpredictable noises in particular. So they're fine unless there's a sudden, loud, startling noise, and that can be quite anxiety provoking for someone. But on another day, they might be absolutely fine walking through a busy shopping centre, because that background hum is there all of the time, and it mightn't be as distressing for the person. So it is important to know that while people with autism tend to have higher sensory needs, that it does vary from person to person, and it's so important to get to know the person's sensory profile. Occupational therapists can be really useful in this regard to help work through what somebody's sensory profile looks like and come up with what we call a sensory diet that the person can engage in to help them stay regulated throughout the day. So again, somebody who finds things overstimulating might need time-out zones. They might need places to get away from so that they can regulate their sensory experience and take time to come back down in a busy world. For other people who have low registration, they might need activities to get them moving, to get their sensory experience up so that they don't feel so disconnected from the world around them. So things like using exercise balls or going out for walks or going on a trampoline, those kind of things can be helpful to increase somebody's low registration. But I would recommend an OT assessment to look at somebody's sensory profile and to put into place a sensory diet that might support their needs. Not everybody will need a very specific sensory diet, but it's always helpful to consult our OT colleagues in this regard. When we're talking about autism and more severe to profound intellectual disabilities, we tend to often have people who fall into what we call the non-verbal category, or people who don't use verbal language to communicate. I don't particularly like the phrase non-verbal because I think it's a bit reductive in terms of people's communication. When we're talking about communicating with people who have autism and a severe to profound intellectual disability, we talk about using what we call a total communication approach. And our speech and language therapy colleagues can fill us in a little bit more on exactly what that looks like. But the bones of it is using all methods of communication to effectively communicate with somebody. So using your body, your voice, your tone of voice, objects in your environment, what's expected of you. They're all ways of communicating effectively with somebody. And it's about integrating them so that we have the most meaningful communication with people as possible. There is a higher incidence of pica, or eating of non-food items, in this category. Sometimes it can kind of be generic eating of non-food items, or sometimes it can be something more targeted, like the eating of cigarette butts or dirt or soil. There's often a level of gait problems or walking problems. with people in this category. So it's really important to be aware of issues around depth perception, issues about the ability to step over thresholds, and if somebody is at an increased risk of falls, to make sure that there's a fall support plan in place for that person. So looking at their falls risk in different environments and making sure that the staff are doing things to reduce the likelihood of that person having a fall. Many people in this category will use other people's bodies as tools. So they might take you by the hand to bring you over to something that they want. And they mightn't be able to show you exactly what it is. So there is a bit of kind of detective work on your behalf as the person's communication partner to try and interpret what they're communicating, what need or want they are communicating with you, and to try and meet that need as best as possible. And there's an increased risk of self-injurious behaviour in this category. So an increased risk of communicating using behaviour that can be damaging to themselves. So when we're talking about that there, we're talking about things like head banging, maybe banging of the hands on the person's legs. It might be scratching themselves. There's lots of different types of self-injurious behaviour, but it's any behaviour that increases the injury to self. Usually when people engage in self-injurious behaviour, it's a sign that they're having a difficult time. It is a communication of distress of some kind, and it is the person's way of trying to regulate, both emotionally and sensory regulation, to trying to bring themselves back into a non-distressed state. While it is important to reduce the risk of injury, we don't want to intervene in somebody's ability to regulate without providing them an alternative. So we never take away a regulation strategy without providing an alternative. Now, while obviously reduction of harm is so important, and if somebody's banging their head off the wall, we might recommend things like, placing something between their head and the wall, like a cushion, to reduce the impact of it. But what I really want you to focus on is looking around to figure out what is the source of distress for that person. Is it internal? Is it something that's happening in them? Or is it external, like a noise that could be reduced or stopped? We're going to go through the internal and external triggers for distress in a couple of minutes, but I just thought it was important to mention specifically in relation to self-injurious behaviour. So signs of distress. So any change in behaviour, increases or decreases in what's typical for that person, can be a sign of distress. Increased self-regulatory behaviours like more spinning, more rocking, more pacing, more hand flapping. They're often signs that somebody is dysregulated or in distress. Increases in self-injurious behaviour. Withdrawal or disconnecting from the people around them even more than normal. Changes in appetite. Increases in ritualistic behaviour or an inability to transition between tasks or places. And physiological changes like an increase in sweating, digestive issues like constipation or diarrhea, and increased heart rate. They're all things to be on the lookout that might indicate that somebody is in distress. So, as I said earlier, triggers of distress can be broken into internal and external triggers. So when we're talking about internal triggers for distress, we're talking about things like medical issues. So pain, epilepsy, gastric problems, constipation. There is a high pain threshold in many people who have autism, and they're often in quite an extreme level of pain before they're communicating even mild pain to the people around them. So it's extremely important to be aware of chronic pain issues for people in this category. Things like headaches, gastric discomfort, dental pain, pains in joints. So, if you're talking about somebody who's in their 50s, 60s, 70s, 80s, is there arthritic pain going on? It's really important to be aware of that and to monitor somebody's pain and know what their baseline looks like. So we always recommend keeping a baseline pain tool for people who have autism and an intellectual disability, and that tells you what they're like on an average day pain-free, so that if there is a difference, that you might be seeing some behavioural changes that might be indicative of pain. So there's lots of pain tools available for people with intellectual disabilities, like the Abbey pain tool. I can't think of the others, but there are a number of others. Being aware of somebody's epilepsy, so are their seizures under control? Do they have seizures frequently? If so, how do they present? Is there jerking of the limbs? Do they present as more like absence seizures? So being aware of what somebody's seizures look like. Often before somebody has a seizure, there can be behavioural indications that the person isn't quite feeling right. So knowing what that looks like for the person you are supporting, knowing what it looks like just before they have a seizure, what it looks like during a seizure, and how they recover post-seizure. So having a really good epilepsy care plan in place is going to give you a lot of information about how to support the person who might be presenting with distress pre, during, or post-seizure activity. Gastric problems are quite common in people who have autism, so being aware of what any gastric issues that the person might have. Are they prone to constipation, diarrhea, wind that's causing pain or discomfort, and being aware of what their average gastric process looks like. So if they're prone to constipation, is there a constipation management plan in place? If they're prone to diarrhea, is there a management plan in place for that? What's a normal length of time between BMs for the person? And if they go over that, what is the protocol that's in place around managing that? And the second internal trigger for distress can be the need to seek or avoid sensory input or stimulation. And that's kind of what I spoke about previously in terms of the over or under registration piece. So, does the person need to move around more? Are they just really finding it difficult to be inside in a small space? And do they need to get out and walk? Is that the thing that's causing them to distress? Or is it avoiding sensory input? Are they in a crowded environment? Are they finding it difficult because of a particular type of clothing that they're wearing that's causing sensory input? The need to self-regulate, using or seeking repetitive behaviours. Other internal triggers of distress could be OCD or anxiety, both which commonly are comorbid or overlap with autism. And the difficulty communicating their needs. So as we said, there's a strong overlap between communication difficulties and people who have autism and intellectual disabilities. And that can obviously be very frustrating. So if you want to communicate a need or a want to a staff member who usually supports you to get that need, but you can't seem to get the message across to them, that's very frustrating for people. So being aware of those issues. External triggers for distress look at things like disorganized environments, unstructured time. So unstructured time is often described as downtime or relaxation time. And while in theory there's no problem having downtime and no problem having relaxation time, if that time is completely unstructured for the person you're supporting with autism, it can be very difficult for that person to know what to do in that time, what's expected of them, what are the options that are available to them. So while not necessarily having to have downtime completely structured to within an inch of its life, it's really helpful for the person to know how long is the downtime going to last for, what are the activities they can be doing during it, how do they communicate if they want to stop or if they want to continue it, and having those there as backups so that the person understands what's involved in those times. Other issues like unexpected changes in routine, so having to cancel plans last minute, or if you always go swimming on a Tuesday and the swimming pool is closed next Tuesday, communicating that to the person. Unclear communication by others, so difficulty interpreting what other people are saying, especially if they're using a lot of language. Expectations of the environment not matching the person's abilities, so frustrating issues like if you are a wheelchair user being in an environment that is not easily accessible for you. Social situations can be difficult for people with autism, things like large crowds, unclear expectations of other people, so competing demands, being unsure of social rules, so things like being in mass, in shopping centres, at a GA match, at a football match, those kind of things can be challenging. And challenging doesn't mean we should avoid them. So if the person really wants to go to a football match, because that's something that they're really interested in, it's about facilitating that and trying to do it in an autism-friendly way. So having your structure, your routine, your expectations, having backup plans, like if it's too noisy, having noise-cancelling earphones with you, or choosing to be in a less crowded environment, maybe starting with a kind of a smaller football match that has fewer people that you can potentially walk around the pitch in. Something, it's about taking into consideration the person's wants and needs and the demands and things that they find challenging. And then sensory features in the environment, like excessive noise, lights, other people standing too close to them, or somebody unexpectedly touching them. So one thing I always say to the care staff, if you're supporting someone in particular through intimate changes or toileting issues or showering, don't touch someone without telling them that you're going to do it. So a simple thing like, I'm going to help you, Johnny, to take off your t-shirt. So I'm just going to help you by taking your hand and then taking off your clothes. Just a small little thing to let somebody know before you touch them. So responding to distress. Firstly, a proactive plan should be put in place to reduce the likelihood of things occurring that are known to distress the person. So this should be included in their personal care support plan. So things like John becomes distressed when his back is to people and prefers to be seated with his back to a wall. So John's a wheelchair user, and it is up to the staff to know where to help John when he enters a room. So if you are bringing John into a room and you are seating him at a table with other people, you don't want to seat him, let's say, with his back to the door so that people can come up behind him unexpectedly. We know this because we've had a long time of getting to know John, and when this happens, he becomes distressed. So the staff members who know the person really well, who know what their likes and dislikes are, who knows what their routine is, who knows how they like that routine to be carried out, should create a very detailed personal care support plan. This is put in place so that if a new member of staff starts or relief staff comes in, that they can read this plan, and at the end of it they will have a much better understanding of how the person likes things to happen. And this creates a sense of predictability and routine for the person. So even if the familiar staff aren't there, that the routines happen in a familiar and predictable way. Acknowledge the person's distress. And this is a step we often skip. So often we go straight to helping somebody if they're distressed. So we go straight to, it's okay, things will get better, I'll just do this now and everything will be fine. But taking a step to acknowledge somebody's distress is so important. Validating their distress, validating their experience. I can see Ailish is upset. Ailish is hurt. I can see Ailish is in pain. Naming the emotion for somebody when you see it can help them understand the internal experience that's happening for them. I know Ailish is sad. I can see that. And then sit with them. Offer a distraction. Provide a safe space for them to calm down if they're distressed. So that might mean moving the person to a quieter environment or facilitating them to go there. Or it might mean moving other people out of an environment if they really can't tolerate moving themselves, to give them space to calm down. So responding to behaviours that challenge. It's phrases that is starting to kind of go out of modern literature, challenging behaviours that challenge. Because when we talk about behaviours that challenge, we're really talking about behaviours that challenge the staff or people who are supporting the person. They're not necessarily challenging for the person. So when we talk about behaviours that challenge, really what we're talking about are behaviours that indicate that the person is in distress. So the person is communicating distress to you, either through self-injurious behaviour or behaviour that is challenging to you. If somebody engages in behaviours that cause harm to themselves or other people, a referral should always be made to the clinical team that support that person to provide individualised strategies for support for them. So if we know that somebody has a history of, let's say, throwing things at the staff member in order to communicate that they want to be left alone, then if somebody is throwing something, they're communicating they want to be left alone. What the clinical team will do is to try and intervene to provide safer, more, suitable ways of communicating that to the staff. So we might do things like introduce something like a break card. So if somebody needs a break and wants you to leave their environment or give them alone space, that instead of throwing something at you, that they can learn to point or show you a break card instead. So it's always beneficial to contact the multidisciplinary team to ask for advice around that. So supporting adults with autism, what can you do? So in terms of medical issues, be aware that people with autism have a high pain threshold. They often have difficulty describing and locating the source of pain. So somebody might say that they're in pain by rubbing their stomach, but that doesn't necessarily mean that the pain is in their stomach area. It could very easily indicate a headache. So again, knowing the person well, knowing how they tell you they're in pain or how they tell you they're sick, and having plans in place to respond to that. There's a need for other people to be vigilant to the person, avoiding uses of parts of their body. So something like not using their right hand to get things and picking everything up with their left hand might indicate that they've hurt their right hand. Or excessively touching part of a body, like constantly touching their ear, might indicate that there's an earache. Areas to be particularly vigilant are around teeth pain, ear pain, migraine and headache, UTIs, urinary tract infections, stomach issues such as digestion or constipation. So complete a pain profile for each person you support, and that gives you the information you need to know what they're like when they're not in pain, how they communicate pain, what are the most likely sources of pain, and how do they respond to pain management. Sensory or self-regulation, so rocking, tapping, complex body movements like spinning or rubbing of the hands together, or finger flicking or hand flapping, or a number of other routines. What we'd say is we really recommend don't interrupt this unless it is causing hurt or pain to themselves or somebody else. So these routines are often the person's way of regulating, of feeling grounded within maybe a chaotic environment. Offer alternatives that might be in line with their sensory profile if it's really interrupting their routine or if it's really interrupting with their daily life. So let's say, for example, if somebody does lots of rocking, that might indicate that they need a lot of that type of movement. And that type of movement might be replaced by having a swing that the person can use. So sitting on a swing might give them that same sense of movement and might be a way to enjoy the garden or get out and enjoy a space with other people that they live with or family members. And having sensory breaks and sensory tools that might be helpful to support the person. So somebody might benefit from the use of a weighted blanket, or they might benefit from sensory breaks like walks in the garden, or breaks like going to use a sensory room. And again, like I said earlier, this is always done in conjunction with our occupational therapy colleagues. They're really the experts in this area, and they will do individualised supports around the person's needs. So, as I said earlier, triggers of distress can be broken into internal and external triggers. So when we're talking about internal triggers for distress, we're talking about things like medical issues. So pain, epilepsy, gastric problems, constipation. There is a high pain threshold in many people who have autism, and they're often in quite an extreme level of pain before they're communicating even mild pain to the people around them. So it's extremely important to be aware of chronic pain issues for people in this category. Things like headaches, gastric discomfort, dental pain, pains in joints. So, if you're talking about somebody who's in their 50s, 60s, 70s, 80s, is there arthritic pain going on? It's really important to be aware of that and to monitor somebody's pain and know what their baseline looks like. So we always recommend keeping a baseline pain tool for people who have autism and an intellectual disability, and that tells you what they're like on an average day pain-free, so that if there is a difference. Communication of somebody's needs, so using PECs, love, typing, gestures, vocalization, language, etc. Communication passports, communication matrices are often really helpful in terms of the staff understanding the person's communication style and learning how to appropriately respond to the person. Remember, the onus is on the communication partner to interpret communication efforts of the person and respond appropriately and consistently. Frustration can obviously build significantly when this person's needs are not met and their communication is not understood. But it is important to acknowledge that this is difficult to do all of the time. So it can be very difficult to get it right all of the time. And all we do is ask that you as the communication partner take time to get to know the person's communication style so that you can most accurately respond to them. And again, our speech and language therapy colleagues can offer further advice in this regard. So supporting adults with autism, what can you do? Providing structures. Remember that someone with autism never really knows what's coming next, that they have difficulty with sequencing of events. So even if somebody has experienced the same routine over and over and over again, there may be an underlying anxiety about what is to happen next. And often people we support with autism need lots of reassurance around their daily routine, their daily schedule. So providing structure, reassuring the person about the sequence of events, using check-ins, avoiding sudden changes to the plan, clearly communicating, often with the use of visuals when there are changes, handling changes proactively, looking for an opportunity to present choice in every routine, and incorporating backup plans for when things don't go to plan. And that bit about choice is so important. So for somebody to feel control of their own life and to have really meaningful engagement with their life, they need to have constant choices. And when somebody is in residential care in particular, but even in day service care, we often just say, this is what's happening next, or this is what we're doing. And there's very rarely an opportunity for someone to exercise real choice within their day. So it's so important that in every single part of the person's day, they are included and that they have choice in it. So from the moment they get up, do you want to get up now? Do you want to get up later? What time would you like to get up? What would you like to do first? Do you want to have a shower or have your breakfast? What breakfast would you like? Do you want eggs or cereal? So using those options and giving the person choice in a way that's meaningful for them. So if they don't really understand what you're saying, having, pictures or physical choices available for somebody to choose something, and being patient with building up their ability to make a choice. So don't say things like, well, they're not able to make a choice. Everyone's able to make a choice. It's just giving the person experience and lots of opportunities and showing them how to do it over a period of time that builds up their capacity to make choices. So that last video, I think, does a particularly remarkable job at describing what autism is. And the bit I particularly like is how it describes the issue of sensory overload. It's the idea of having crossed wires in your brain that when they all fire at the same time just becomes so overloading that you can't quite take in any of it. Another person that does a really, really good job at describing what that sensation is, it feels like, is a lady called Carly Fleischman. And if you haven't seen her before, I highly recommend you look up her YouTube videos. Carly is a young woman who has autism, and she communicates through the use of an iPad. So she types out what she wants to say. I think Carly presents as many of the people we support, the adults we support, in that she doesn't use language to communicate verbally. And often we can underestimate people who don't use language verbally to communicate with us. And often we assume that they don't really understand what's going on. I think what's really interesting about Carly's videos is she shows you just how tuned into everything she is, and Carly doesn't have an intellectual disability with her autism, and her way of describing her sensations, and the sensation of having to look people in the eye as being like having to take a series of photographs and put them all together, or the sensation of feeling touched, being touched by somebody else's, feeling like there's spiders crawling all over her skin. I won't try and do her justice by explaining it to you, but I would recommend that if you are further interested in exploring autism, watching her videos can really give you another insight into what it's like to have autism from somebody who experiences it. So, as I said, the focus of today's presentation is primarily on autism and people who have intellectual disabilities, and that is the service that I work for. So we're going to talk about, firstly, autism and a mild to moderate intellectual disability, and then the combination of autism and a more severe to profound intellectual disability. So firstly, mild to moderate. So the first thing to be aware of with people who have autism and a mild to moderate intellectual disability is there tends to be delayed language development. That doesn't mean that language or verbal language is non-existent, just that people in this category might have difficulty communicating. They might use repetitive use of learned phrases or echolalic phrases, which is that learned set of phrases that they repeat. Sometimes those learned phrases are meaningful and they are communicative, and sometimes they're used as a tool to self-regulate. Often people in this category will understand more than they're able to express in terms of their communication. But it is still important to remember that their language development is probably delayed. They may have difficulty understanding large chunks of information, so it's important to take time when you're communicating with someone with autism to communicate clearly, effectively, chunk information together that goes together, do it in sequential order. So, if you're giving a set of directions, give them in the order that they're to be completed, but ideally trying to give one instruction at a time. Give people time to process the information. They may have visual perception problems, so depth perception issues, walking down a stairs can be difficult, or stepping over thresholds. Perception of a person's face. Communicate clearly with the person using visual supports. So visual supports are helpful for many people with autism. They're not helpful for everyone with autism, and some people have a clear preference for not using visuals. I've worked with clients before who have asked not to have visuals in their home. They don't find them helpful and they don't like how it feels to use them. So checking in with the person whether visuals are helpful, and also communicating with our speech and language therapy colleagues to see if visual supports are helpful, what kind of visual supports might be helpful for the person. So if somebody has a communication style where they are here and now thinkers, they find it difficult to think about the future, and they make decisions kind of in the moment. For those type of communicators, social stories, let's say, may not be helpful. They might find it difficult to understand them, they may not make much sense to them, and they might find it hard with that overload of language. But something as simple as a first then card might be quite helpful for them. So first we're having breakfast, then we're going to day service. Whatever it is as part of the day, communicating with our speech and language therapy colleagues about what kind of visual supports might be helpful, whether real photographs might be more helpful than symbolic pictures, whether the person might need objects of reference or objects to describe what's happening. There's lots of different ways we can support the person's communication. So things like visual schedules or timetables can be helpful for some people. So arranging the schedules from top to bottom or left to right, and allow a way to check off or remove a task when it's done. So having the little symbols or pictures on Velcro, so when the task is completed you can take it off and place it in a finish box, or having it on a whiteboard for somebody who's literate where you can wipe it off or cross it off when it's completed. When we're talking about autism and more severe to profound intellectual disabilities, we tend to often have people who fall into the non-verbal category, or people who don't use verbal language to communicate. I don't particularly like the phrase non-verbal because I think it's a bit reductive in terms of people's communication. When we're talking about communicating with people who have autism and a severe to profound intellectual disability, we talk about using what we call a total communication approach. And our speech and language therapy colleagues can fill us in a little bit more on exactly what that looks like. But the bones of it is using all methods of communication to effectively communicate with somebody. So using your body, your voice, your tone of voice, objects in your environment, what's expected of you. They're all ways of communicating effectively with someone. Mini schedules can be particularly helpful of things like breaking down an activity into manageable steps. This can be really useful if you're trying to teach a new skill, like getting dressed, getting undressed, showering, washing your hair. Not just personal skills, but domestic tasks or other tasks, more complex tasks like work-related tasks. Mini schedules can help give somebody a visual reminder of the steps involved in an activity, and breaking them down into manageable steps and putting them in the sequence that they are due to happen can help the person go through the steps in a systematic way. Social stories can be helpful for people with higher level language abilities. So social stories aren't just easy read information that provide information that's accessible to someone. Social stories also tell the person what's expected of them in a particular situation. So for example, Ailish's plan about the bus. Most Mondays, Ailish gets the bus home from work. Other people are usually on Ailish's bus too. When Ailish sits down in the bus, Ailish will try to wear a seatbelt. Ailish can try and listen to Ailish's music using headphones when the bus is too busy. When Ailish goes home, the driver might help Ailish by opening the door so Ailish can get out. Well done, Ailish. You can see this social story tells the person the expectation of what's going to happen on the bus journey home, but also puts in place things that the person can do if they're finding it difficult. So you can see Ailish will try to wear a seatbelt. It can be difficult to have black and white rules in a social story. So when you're saying Ailish will wear a seatbelt, if there's no seatbelt available on the bus, that might make me very anxious. So by putting in grey phrases like will try, it can really help the person not place things in black and white rules. Expectations of the environment. So think about what might be stressful for the person when planning their day. Try and find a balance between low stress and high pleasure activities for the person. Nobody wants it to be the other way around. Nobody wants something to be high stress and low pleasure. Most of us wouldn't do something if that was the case. So when we're supporting somebody, it's really important to try and find that balance. Include breaks and time to engage in self-regulation, like listening to music, going to a quieted place, having a cup of tea. But again, remembering the thing I said earlier about unstructured time. So even within breaks, having it routine, structured and predictable so that the person knows how long it's going to happen, how they can get out of it if they want, and what's expected from them in those times. Remove any stressful tasks or activities that are not essential, particularly if the person is unwell. So if there's an unessential, really high stressful task that the person just is very distressed engaging in, you really have to ask the question about whether it is essential to have it, and does the person really need to be doing it. It's so important to incorporate tasks that the person enjoys. You are looking at improving somebody's quality of life and increasing the amount of time they spend enjoying themselves. It's important to include people as part of that, and that they get to spend time with the people they enjoy spending time with the most, the people who are most meaningful for them. Family, friends, favourite staff. Take opportunities to genuinely and specifically compliment the person. So thank you for helping me to set the table. It was really funny the way you told that joke. So rather than generically saying things like, oh, you're a great help, specifically compliment the person on what they're helpful with. Social issues. People with autism spectrum disorder can find it difficult to predict what other people will do. Therefore, it's important that we act in a predictable way at all times. So for example, if a doctor says, is it okay if I look in your ears before doing it? That creates predictability, and it creates a sense of security for the person, that I know this person isn't going to touch me without telling me first. But also that you as a staff behave in a predictable way towards the person. So it's often not helpful, to be the type of person that jumps around or all of a sudden jumps out and somebody to go, hey, how's it going? And you might mean it in a really nice way, and you might be trying to be fun and enthusiastic and bright and bubbly, but actually for somebody with autism that can be very unpredictable. It can be very difficult to engage with you, so that you always behave in the same way towards the person, keeping the same kind of tone of voice, the same way of interacting with them, and always letting them know what you're going to do before you do it. People with autism spectrum disorder can be unsure of social rules and can find chit-chat difficult, and they can often be very truthful or find it difficult to tell white lies. So often people with autism are perceived to be rude. It isn't really so much rudeness as just not being aware of the social rules about not saying something. I always give the example of my mum was going to a wedding one time, and my cousin has autism, and she had bought a lovely, very expensive flowery dress. She was all dressed up for the wedding and the occasion, and all the family were together, and my cousin said to her, "Jesus, there's an awful lot going on there," and we all fell around the place laughing. It wasn't wrong, it was a very busy dress, but if you took that as insulting from the person, I think it would be probably much more difficult to arrange or to create a sense of relationship there. So being aware that people with autism can find it difficult to follow social rules, and they may say things that are not necessarily insulting, but are kind of extremely truthful. And people with autism are often seen to not enjoy the company of others, but I think it's safe to say that they often do enjoy the company of others, but that they also may need to balance this with spending time on their own. Sensory issues, so avoiding strong sensory stimuli where possible, but particularly at times when the person is paying attention or managing a stressful situation. So like doing housework in the house, like drilling, banging doors, or loud voices, background music, strong smells. So if the person is distressed, removing excessive sensory input. Avoiding simultaneous multisensory stimulation, so having a very bright light in a crowded area with background music and having strong smells and movements. So you can see things like shopping centres and restaurants can be quite difficult for people who have autism because of these issues. So many of them do autism friendly hours. It's really important to check with your local area. A lot of shops, shopping centres, food places like SuperValu, Dunn's, Tesco do autism friendly hours where they turn off the background music, they dim the lights a little bit more, and they remove as much of the sensory input as they can. A lot of cinemas do autism friendly screenings where the light is at a more dimmed level and the noise isn't quite as loud. So it's really important to check in and see what is available in your local community in terms of autism friendly environments. And remembering that different types of sensory input can be distressing for different reasons. So for example, sudden unexpected noise like a dog barking or a telephone ringing or someone coughing or clicking the top of a pen can be distressing because it's unpredictable and you don't know when it will end. Whereas a high-pitched continuous noise like a small electric motor used in a kitchen or garden equipment can be distressing because it's relentless. And confusing or complex or multiple sounds like lots of people talking at once or busy shopping centres can be distressing because the noise is difficult to make sense of, so it's confusing and overstimulating. So that's the end of our basic autism awareness introductory session. Thank you all so much for listening. If you have any questions, please contact me via email or phone, which you'll find through the Cheeverstown system. And we will also follow up with more person-specific workshops if you feel that's helpful. So while this gives you general information about what autism is and how to generally support someone with autism, we're also happy to provide more detailed workshops about particular people who might have a diagnosis of autism that might be having a distressing time or you might be struggling with. So please feel free to get in contact with me. Thank you for listening, and goodbye.